Mr. Tibbetts to come into the chambers, please. Not you, the chairman of the HSA board. Call the meeting back to order. Mr. Tibbetts, thank you very much for taking the time to come to appear before the committee. And today we're looking into the Auditor General's report entitled Ensuring Quality Health Care and Health of Population. And most of the things we wanted to talk to you today is what kind of lines of communication do you have with the ministry in terms of government policy as opposed to operational matters of the HSE?
Good morning, Mr. Chairman. Thank you for having me today. Recently, we had have meetings with the ministry on a quarterly basis, and what we've done recently is we've actually got the ministry to put representatives on the HSA board so that there's a direct communication now between HSA and the ministry. In fact, the first sitting in January of this year has had two members, one from Ministry of Finance and one from Ministry of Health, sit on the board as an invited guest to the HSA board.
But those sitting on the board, are they going to be more involved with the actual operational aspect of HSE?
Well, as you're aware, Mr. Chairman, the board itself does not get involved with operational matters. We deal with policies and procedures. So basically the idea is that the communication is more open between the Ministry of Finance, the Ministry of Health, and the HSA itself. Therefore, the delay that sometimes seems to be the case in the past would hopefully be either eradicated or more streamlined.
I think you're misunderstanding the question I'm asking. I understand fully that the board, when it comes to the operation, is responsible more for policies and procedures that the HSA is to follow. But what I want to do is distinguish between the operation and the functioning of the HSA as an entity, the delivering health care, versus the board having a role in advising government on policies based on your operational issues that you might have that would lead. What method of communication do you have formally how do you get policy guidelines from the ministry, and how do you respond, or how do you propose policy changes to the ministry in terms of the overall healthcare?
Okay, so communication would be from directives issued by the ministry, either through the councillor or chief officer, then passed on to myself and the board as a whole. We then, of course, discuss the best ways to implement those and in discussion with the senior management. And in reverse, very similarly, any queries or concerns, senior management, the board then corresponds back with the ministry through the chief officer, through the Councillor McTaggart, and that's how we have the communication between the two. So basically, it's a chain that works both ways for the organization.
What monitoring or mechanisms exist at the ministry level to determine whether you are in fact achieving the outcomes intended by the policy, and how do you demonstrate to them that you are achieving those?
So what we've done in the last 6 months since September of 2016 is we've created an action item log. So for every single meeting that we have, whether it's a subcommittee or a formal board meeting, there are action items that have been identified with timelines, outcomes, and so forth, listed and people responsible for those actions. Those are then conveyed back to the ministry so that they're aware of, when they're completed, scheduled completion times. That's been something that we put in place, like I said, in the last 6 months, and we found it to be very, very helpful. We've actually, through that, found out that there are items outstanding going back years, and we're working. We've closed a number of those items off in just the last 3 months alone, but we're working to finish up all those from you and previous chairman on the board, and working to give a better, more transparent information to the ministry so that they're well aware of their directives being pursued and worked after, and can see the actual timeline for when they're going to be delivered to them.
Do you include timelines for the ministry as well when you request things from them?
We have any requests give a deadline or timeline as to unexpected return. So if
what is your experience in terms of the ministry making your
The ministry has been, especially under Councillor McTaggart, has been very efficient. We tend to get responses quickly. Not always the response we want necessarily, but we do tend to get responses. Like I said, Chief Officer and Councillor McTaggart have been very, very efficient, either in email or WhatsApp or by phone conversation to get responses back to us. I must credit them with always being available to the HSA. I've never had an opportunity when I've called and they've not answered or returned the call expediently.
In terms of the HSA accommodating the public health function, has the board encountered any problems in being able to deliver that output or outcome to the ministry?
I would have to say every area has its little nuances. And public health is no different. We have had some instances, especially with the recent Zika outbreak, where we had to go back to the ministry and work with them to get some of the outcomes delivered. Being able to test locally and so forth for Zika has been an issue. So we worked with the ministry on that, found a workaround to be able to make it happen. Always the communication is the issue, and once you're able to communicate, which I think this board, this senior management team has been very good in being able to communicate with the ministry. Like I said, I cannot say enough for the chief officer and the councillor in their communication with the board as well. The councillor several times coming to visit with the board, and being able to sit at board meetings has been very helpful for us. He's been invited on 2 occasions and been able to come, so it's been very nice to have that openness with the ministry. But as far as public health in particular, that was the only major instance I would say of any issues when it comes to being able to deliver the outcomes. And like I said, a quick meeting with the board, the senior management, the chief officer, and the councillor was able to rectify it and find a solution. What policy now have you recommended to the ministry, or what policy has been put in place to reduce the need or to better enable you to deal with something in the future, like a Zika outbreak, without having to go back for them for operational guidance? But with the chief officer sitting on the board now as an invited guest, and Ministry of Finance having a representative on there, that would eliminate the need of having to go back and recommunicate, because she would therefore have instant access to what's available.
Don't you see any conflicts in having the chief officer actually sitting on a board that she is expected to have oversight over in terms of performance?
She sits on as an invited guest. She's a non-voting member, and as such, she's there for information gathering, basically, where she will be able to better understand discussions and communication between the board and other entities. If there comes a time where there is a conflict as far as the board having to make communication with the ministry, she would have to be excused at those times.
Don't you see any risk in the fact that she's sitting there for information gathering, or is that an admission that the information that she needed to have from the board was not forthcoming and available, and therefore we have now amended the law to make her sit on the board? And do you see a risk in not having a formal method of informing the ministry, as opposed to the person sitting there and the expectation then, well, you was here, you should have heard what they said, you should have done something about it?
Yeah, Mr. Chairman, the idea has never been that the information was not forthcoming. The idea was to expedite any kind of decision making, so that the chief officer herself could say, I have the information. There's no need to wait another 3 weeks to have another meeting, or the following month and so forth. So there was never an issue of the ministry not getting the information. Everything the board does is openly transparent for anyone. And
you're not suggesting that putting the chief officer on the board, there's an expectation by you as board chairman that they're going to make decisions in the board meeting representing the Ministry of Health?
No, the ministry makes their own decisions, and they would pass them on to us formally in writing. The chief officer would never come to pass a directive on to us. She would share information if she has it from the ministry, and we would request information from her as well, from the ministry.
And what is the purpose of requesting that policy change, to have somebody from the Ministry of Finance sitting on your board as well? What is the genesis of that request?
With the Ministry of Finance, in meeting with Minister Archer, it seems to have been disconnect throughout many of the ministries, and there's the indigent risk or indigent population output that we need to deal with, as well as Cineco and all the other insurance needs. So the Ministry of Finance representative is there to, again, better or more efficiently transfer the information back and forth with us to the Minister of Finance. It allows us to be able to get information on outputs as far as what's still available quicker, rather than having to, again, send emails or take the time to have another meeting with another, well, basically the same representative that could be sitting there. So it allows a better, more efficient reporting method, allows us to get information as well quicker than having to wait a month or 2 months to get back from someone that may be on vacation or whatever the need is. So it's the entire purpose is to improve efficiency.
You're confirming my concerns, is that you've put these people there and you're expecting them to, at the meeting, make decisions.
No, sir. I said to give
because
information.
they're still have to, you're still going to have to go. So you're going to duplicate the effort, then you have them sitting there.
No, to pass information is what I said. I didn't say to make decisions.
But what is the point of them being present to pass information if it is not to enhance the decision-making process?
There are many reasons for the information to be passed along to us. It may enhance our decision as a board, but it's not going to, they're not on the board to be able to make a decision. They don't vote. They don't give us they don't give us decisions or make decisions on behalf of the Ministry of Finance or the Ministry of Health. It's for information and streamlining information.
You don't see any conflicts or intimidation possibility of having these two high-level people above as part of your independent board, even though they can't vote, sitting there?
They don't sit on that board, and I don't view them as above me in that case, because they are invited by my board to attend, and at any time we can remove the invitation. So it's
so we've gone to the extent to request a policy change, to amend legislation, to put those two people on the board. Mm-hmm. But the reason for that was not based in them being able to get information that they weren't getting and being able to more effectively make a decision, and you reserve the authority to say to those two members that we need to leave the room so we can make a decision?
That could be conveyed to any board member, actually, if they need to be recused.
But that can only be, there's only certain
Yeah,
conditions.
right, there's certain conditions. and
Under Robert's
conflicts.
Rules of Orders that you could invoke that. If you try that with me as your board member, you better have your ducks in a row.
Well, that's what I'm saying. And it could be myself as the chairman. It depends on the if there's a conflict.
No, we're not talking
But-
here. We're not talking here about personal conflicts
Right.
or
or business conflicts. right.
anti-corruption
Right.
conflicts.
Right.
What we're talking about here is people to whom you should have a client relationship. In many respects, these two people, you are the client, you are their client, and you should be making decisions independently based on the outputs that they have purchased from you to deliver a certain outcome. But we've now gone and put them on the board, right? As non-voting members, and you don't see any inherent conflicts of that.
There's always the potential for conflict, but to say that that it's apparent and inherent, I don't see that being the issue in this case. It is for information is the reason why they're on the board. It is not for decision making as far as their ministries are concerned, but for our information.
How do you separate the two at board level?
Well, if they need to be questioned as far as specific outcomes or potential, future legislation or whatever it is, it allows us a quick and direct communication with those ministry representatives. As far as I am aware, Mr. Chairman, the board chairmen are responsible to the ministers themselves. So I don't see a chief officer necessarily as a conflict. I see them as a the chief person in the ministry, but it's at the pleasure of the ministers.
But constitutionally, and I don't have the statute, the HSA statute before me, but isn't it the ministry and the person that has administrative control over you as a board chairman is the chief officer and not the minister? But the minister is more confined to policy.
I would have to look at that. I don't know for sure.
So these things were not considered when.
Well, as far as when I signed the purchase agreement on behalf of the HSA is with the minister. So I'm not sure where the chief officer falls as far as whether she would sign it or not, but.
Mr. Chairman, good morning, sir. Good morning. Yes, it is. Just to obviously say that when the government's annual budgets are debated by the Legislative Assembly and examined in Finance Committee, those budgets are set out in the form of an appropriation bill, which when passed obviously becomes an appropriation law. The appropriations in the law are obviously arranged with reference to the responsibility for those budgets to honorable ministers and official members of government, Attorney General, Deputy Governor, and so forth. So the responsibility, budget-wise, rests with an honorable minister and official member. In the case of our discussion now, obviously with the Minister for Health, the relationship between the minister, which is responsible for the budgets, and the chief officer has to present the minister with essentially a monthly billing to say to the minister, this is what the Ministry of Health has done for the ministry on a monthly basis, and I need you to authorize payment of these services that have been provided on behalf of the ministry. And the minister then examines that those details, and if he is satisfied, he would sign, and then the Treasury, on behalf of the Cabinet, would actually fund the Ministry of Health for those services performed. I hope that's helpful, sir.
Yeah, it is helpful and I appreciate it, but I'm still trying to get at the rationale to put these two people on the board, which drove the policy, which drove the legislative changes, if it wasn't because they themselves felt that they were not getting the kind of information to drive their decisions from the board on a regular basis.
Mr. Chair, let me speak very briefly to the Ministry of Finance involvement with the HSA board. It is my understanding that it was felt desirable that a Ministry of Finance representative should be on the HSA board, if you like, to add to financial decision-making processes to improve the finance, to as best as possible, to help the HSA improve its financial standing. It was for that very simple reason, is my understanding, as to why the financial secretary, chief officer of the Ministry of Finance, or his nominee have been invited to. I think we've attended, or my nominee has attended one meeting thus far.
But then I get back to the position. I accept and I accept that that's a good rationale. But why would you put the person there and not give them voting rights? Because if they're there to influence and to help the board make better financial decisions, I would think that they would be more effective if they could vote. Unless, and I don't want to sound too cynical, unless you're leaving a back door to say that when they make an incorrect decision, you can say, well, my person didn't vote, so we're going to still hold you responsible, although he gave you advice to do otherwise. It just from an administrative, managerial, governance concern, I have concerns when you put people to whom you report and put people who perform for the board on the board.
Mr. Chair, if I could just add to the conversation here. Again, going back to our 2013 governance report where we discussed the relationship of SHECs to ministries and through to the minister. We recognized the practice of having ministry officials on boards was not an ideal situation. What you are looking for is full accountability of the boards for their actions and for their operations to the through the ministry to the minister. And then more importantly, and this is where it comes down to, is if you put ministry officials on the board, no matter whether they're voting or non-voting, the ability to hold those boards accountable at the end of the day becomes blurred and becomes less.
Because you were part, your representative was a part of the decision-making process, whether
even
they
though
voted or not.
That's correct. Thank you very much.
And that's the same reason why we keep politicians off the boards. But everybody's quite happy to keep them off, but we keep seeing this creeping back in charge of and part of by the Civil Service Administration. We want to deal today, like I say, more with the policy, your responsibility. Are you familiar with the NHPP?
I am aware of it, yes.
You are aware of it, but that is an indication that it has not been presented to you as government policy with which you are expected to comply.
Mr. Chairman, from my understanding of the NHPP, it was something that was done prior to my time on the board. However, we are working through the board and the senior management of the HSA to continue to implement the points of the NHPP. To say that I can list off the points, I cannot list off the
No,
points.
I don't expect you to commit this kind of stuff to memory.
But certainly
But
I'm
in
aware
your
of it.
orientation, which I assume you had an orientation
Yes,
of being
sir.
appointed chairman, did the ministry not present the NHPP to you as government policy authorized by the highest authority in the land as government policy, meaning the sitting legislative assembly? And therefore, there was an expectation that your operational decisions would be based on these strategic directives in terms of achieving what they want.
Yes, sir. It wasn't specific. I don't think that they specifically said this is the NHPP. Make sure you follow all these directives. They said these are the directives the ministry has. Please make sure they're delivered. And so that's what we do. We go through and we deal with the directives. And from time to time, the ministry will add directives as the need changes as well. So we are aware of them. We are working through them more so in the last year, I think, rather than even in the previous years.
The directives that you receive from the ministry,
Yes, sir.
are they more policy, i.e., we want to make sure that you are developing your human capital to a sustainable level, et cetera, in order to function properly in the global health system? Or are those directives more operational, that we're worried that you're overspending the indigent component, or we're worried?
Strictly policy. Mr.
Strictly
Chairman.
policy.
Yes, sir.
Could you give us an example of one of those policy directives? If you don't have it with you, you can send it to us.
Yeah, I'll
in
have
writing.
to send it to you.
Okay.
They're very overarching as far as the health of the island and so forth, as opposed to very specific or operational matters. They're not finance related necessarily, as far as saying cut spending or anything like that. That's not at all. It's policy as far as deliveries of health to the Cayman Islands.
When you send the ministry your annual audited accounts, do you send them a report along with that, or you just send them the audited accounts in terms of how you have managed to meet their strategic guidelines and where there are shortcomings, or what kind of matrix and stuff do you report achieving those policies?
There would be a report from the board of directors accompanying it, stating where we realize there are shortfalls and so forth, and also identifying where we would be going in the future as far as the being able to meet the following or the remaining strategies.
What kind of response to that report have you been getting from the ministry in terms of facilitating you to meet the outcome that they're looking for?
Well, if, for example, if a specific outcome is identified that there's a major shortcoming, that usually will entail a follow-up meeting with the ministry to identify how we can approach it best, whether it's a national health issue, whether it's perhaps we've had issues with delivery of service because of other institutions and certifications and so forth. So all of those that need to be identified and addressed, there would be follow-up meetings with the ministry. We meet with the ministry on a quarterly basis, face-to-face, and we communicate with them monthly.
One of the strategies that the report itself is concerned about is building capacity, and particularly human development capital. We were told between Wednesday and yesterday that there is a desire to make sure that Caymanian physicians are properly and professionally qualified to international standards.
Correct.
The ministry indicated that they didn't see the training of those physicians as part of the ministry's responsibility, but they thought that the way for them to get that training was to apply for an education scholarship.
Correct.
What has been the board's response to that policy decision?
What the board has done is we've actually met with the Education Council and identified specific needs of the organization and therefore for the health of the country itself as to how further training can assist through scholarships and so forth. So we've actually had sit-down meetings with Education Council in this regard.
What has been the Education Council response to the specific need expressed by the board for board certification postgraduate training?
I can't give details of particular doctors, for example, but I do understand.
No, I don't want it for individual.
Right. But I'm just saying, I can't say they've given X amount of dollars, but I can say that that I do know several of our doctors have been able to receive funding from the scholarship secretariat to be able to meet the requirements for international standards.
Without being specific, can you say you have 5 people off now doing board certification funded by the HSA or one or
By the HSA?
no, by the scholarship? Or,
I can't say how many. I do know, like I said, that we have made representation to them, and that several have been given the option. I don't know whether it's 1, 2, 5, 10. I don't know how many, but I do know that whether they've taken up on it, I don't know that. But I do know that they were identified.
Ms. Mitchell?
Sorry, it was just for clarity. Does that mean that within the guidelines for awarding scholarships, there has been a change to the definition of what constitutes an award? Or is it a discretionary thing within the existing guidelines?
As far as a scholarship secretariat?
Yes.
No, it would be within the existing guidelines, I would think.
But other witnesses have indicated that the existing guidelines are hopelessly inadequate to fund specialist training. So if your representation to the scholarship authority has not led to them accepting the need to amend their guidelines, then how are they accommodating your people?
A scholarship does not have to be a full scholarship as far as being able to cover all the costs, for example. I know in the past the scholarship secretariat has offered scholarships, and in conjunction with other funding, people have been able to attain their certifications.
So you're satisfied that I think the maximum award
Is like $20,000.
Right.
Correct.
You're satisfied that in the instances where your board and the HSA itself needs to enhance its human capital, that you can find other methods of funding the $80,000 that is needed above the $20,000?
I'm not satisfied with it at all. I think it should be, if we're going to train our people, that we get proper funding from, whether it's through the scholarship secretariat or if government so indicates that they want to identify through HSA and a specific channel or outcome that they do that.
But has the HSA looked at its operational profit?
To see if we can fund, yes.
And the question I was asking is that in the absence of the Secretariat changing its guidelines, are you confident that the HSA can provide the remainder of the cost to develop your staff?
Training is always a big issue, and budget for training is a big issue. In any organization, I'm sure HSA is not special compared to many others as well, suffering with the same issues. To say that we are comfortable to be able to complete training for the Caymanian doctors and specialists that we would like to, I can't say we're comfortable, but it is something that we have identified within the organization that we need to increase our budget. If I remember correctly, the budget amount is very small for training, and our HR director has worked very hard to, along with our finance director, to increase that budget so that we can accommodate further training.
Well, I think if you look at your most recent audited accounts, it was in the region of 300,000, but you only spent 40% of it over the year.
That's what I'm saying. Budget is always, training, is always the first thing to be cut in a budget. It's inadequate in any stretch of the imagination. The money that was in for training would.
No, but this is not a situation of where you cut training. This is where you had a budget allocation of 300,000 approved, but you only managed to spend. You did not spend, I think, 128,000 out of the 300,000, which comes out to about 40%, somewhere around it. What is the explanation of that when we are told from this report and by other witnesses of the need to enhance capacity, particularly in the medical field, because the continued use of locums is a very expensive route to go.
Right. I would have to get direction from the CFO to find out why or where the balance of the budget was either not spent or what is reallocated to.
So those questions were not asked when you saw the accounts and saw that it wasn't spent?
No.
You just was okay with it going to profit?
No, sir. They were not asked.
Mason, you had some questions.
Morning, Mr. Davis.
Morning, sir.
Mr. Chairman, through you. In terms of, I guess, the lack of a formulated strategy to carry out the NHPP, can you explain how the board looks at international standards and holds its self accountable to those when carrying out their functions in terms of benchmarking the activities of the hospital and personnel and things like that?
Through you, Mr. Chairman, what we've done in the last, it's been about 18 months now, is we've actually signed on with some organizations that allow us to use benchmarks for similar sized organizations with similar backgrounds as ours to be able to determine if HSA doctors, for example, are performing and if patients are satisfied. You may have received, as I have, calls regarding the surveys and so forth to find out about your quality of care and so forth. So that's something that this board has done in order to see if we do measure up to international standards. Further, as far as the lab is concerned, we're internationally accredited and so forth, and one of the only forensic labs in the area that do meet the accreditations for forensics.
And in terms of formulating strategies for HSC, ensuring accountability, kind of shaping the overall culture, how much influence does the board have up the chain in terms of ministry? How receptive are the recommendations and suggestions from the board to the government arm and the political arm? I mean, do you find that it goes up and then comes back down the way that you've suggested and recommended it in most instances, or can you explain that relationship?
Yeah, through you, Mr. Chairman. The board has, in many cases, sent requests through the councillor to government in regards to whatever the need may be at the time. Most of the time, the response is met with the request in a very timely manner. There have been times when the government has said, no, this is not the approach we want to take, and therefore we've had to revisit and see the best way to look at achieving strategies that the board is trying to accomplish. So I would say the majority of the time of times they are met with a positive response. And again, that is due to very close communication with the counselor and the ministry, and being able to kind of getting an understanding for where the ministry is wanting to go with the HSA.
And the report identifies several opportunities to improve the quality of care, etc. How has the board received this report, and what has been done or is being done post this report? I know it's early days, but have there been any discussions about the report and the way forward based on some of the findings?
Through you, Mr. Chairman. We were only given the report actually this week, so it is fairly new to us. We were made aware of some of the findings, and then being able to read through it has helped. From a board standpoint, we've obviously identified several of the issues as well from prior to even the audit report going out. One in particular, customer care. The organization has instituted a complete training program to train every single staff from housekeepers right through the CEO as far as our customer care service is concerned, being able to provide a higher level of service. This is headed by our HR director, Ms. Carrie Bergstrom, who, as you all may know, is a HR manager for a local firm, and certainly very well versed in these trainings. So we've actually, board members have been invited to visit with the trainings to see what is going forward with the organization, how best we can implement it. But that's going through the entire organization. We've basically been able to get our own people trained, and they turn around and train another set of 6 people, and so forth, until every single person in the organization is trained. Not to say that we won't have loopholes, as in the organization you will find 1 or 2 that there are issues with, but we have identified several of the areas as well, as has been identified in the audit, and I think the report is very fair. And we began the process of reconciling them and improving services as far as quality, as far as customer service, and most recently getting a clean opinion for the financial side.
I know that some of that training budget went to the customer service aspects. And I mean, that's important. I see that you're also doing surveys, and we heard yesterday that those are kind of being followed up on and reviewed periodically. In terms of the mental health aspect of the HSA and some of the recommendations as well in the report, but just we've discussed these now for the last 3.5 years about the lack of capacity in that sector, bedding, the lack of bifurcation of youth and separating them from the adults. What's the board doing in regard to that in terms of trying to suggest more resources, managing the resources that you have, and trying to put that strategic direction firmly in the pathway of looking at mental health as a component of the delivery of health service?
Through you, Mr. Chairman, the board hasn't actually dealt specifically with the mental health aspect of it outside of requesting the government look at it as on a national scale, because we do believe that it's more than what HSA in particular can handle. And as you stated, that there needs to be early identification and assistance to whether they're youth or wherever they can be identified in order to help. And we're not sure that HSA is perhaps the best place to house such a facility. But there has been representation made that on a national level we do need to identify and work with proper institutions that are set up to deal with mental health, because it is a bit different, or in fact completely different from perhaps pharmaceutical and drug-related needs of patients.
But
I don't mean to say that mental health patients would need drugs or don't need drugs. I'm saying
No,
that,
no, but
if there's an illness, usually there's a drug to go along with it. Mental health could be a multitude, an array of different needs.
But you do expect that there is a medical and clinical component of mental
Absolutely.
health that the HSA
Absolutely.
needs to address.
Yes, sir. That is correct.
So
And we currently do, as you're aware. Our concern is that the problem is bigger than what we're able to deal with at the HSE. In the sense of it needs to be addressed specifically on a national level from government.
in terms of what?
In terms of housing, in terms of staffing to properly deal with it, there have been instances.
But I mean, in terms of other issues not related to the medical.
No, not the medical side. No, sir.
I just wanted
no,
to
sir. No,
give
no,
it
no.
opportunity
no,
to clear
no.
that up because
Physical constraints is what I'm referring to. I apologize. It's physical constraints of the actual site that we currently use at the HSE, our sites.
Thanks for those answers. Moving now to the financials and looking at specifically the allowance for bad debts, and we see that's 95 million as of June 2016 from the report. Can you explain to me how the board is looking at that and helping shape what strategies are to reduce that allowance, and where do we go from that figure, and what are we trying to move to?
Through you, Mr. Chairman, this has been the number one priority of the board now for the last 6 months, so much so that we are in the process of, and in fact have just hired on a temporary basis another specialist, a CPA, to come in and work with us, and also given a directive, an RFP is being drafted to bring in a firm to assist with cleaning up our audit. However, this is very closely related to bad debt, and the bad debt issue is one, first of all, is not going to go away completely based solely on the nature of the HSA and the fact that it is a government-based facility. What we would like to do is minimize it. The board has taken a number of steps to minimize, including a payment policy for the pharmacy where we were seeing $5 million per year lost. We've seen a 45% reduction in losses in the pharmacy, with a goal to extend up to over 90% in this calendar year. We've also looked at in bringing in a firm to get a clean audit opinion, formalizing all of the policies all of the procedures that are taking place in as far as revenue capture is concerned. Some of these issues that are dealing with bad debt are evolving because of incorrect, whether it's coding or insurance claim numbers and so forth, and therefore they get sent back after the time period has elapsed, and we end up in a situation where money is then placed into a bad debt account. So if we have formalized procedures in place as to exactly how revenue is being captured or should be captured, we feel that this will greatly minimize the bad debt per year, and therefore allow it to be within a region that we can work with through local collection agencies and being able to identify how to stop some of the leaks that are happening in the HSA.
But what time frame are you placed?
April the 1st.
Because this has been an ongoing thing now for a number of years, and we keep getting the same.
April the 1st, 2017 is the deadline for the firm, whichever firm is selected to begin the process of formalizing.
No, I'm not worried about winning a start. I'm worried about winning a finish.
Well, as I stated, to say that we'll never have bad debt, I think is not a fair statement based on the nature of the HSA, it being the primary health care provider.
I would proffer that through the various allocations in the budget to which the HSA has access, other than the incidents of incorrect coding, and none of those should be classified as bad debt, because once you make the claim with the insurance company before the 90 days has expired, then it continues to be processed and you should eventually get paid. Otherwise, you go to court because you have a legitimate claim. Problem is, if you don't file it within the 90-day period, then you can't file it. As recent as last night, in my district council meeting in our side, I had persons who reported to me if I couldn't do something about them, because when they go to the HSA, they can't pay their bill. And then they get a claim from the insurance several months later, and then they have to, the example they gave to me is they went there 4 or 5 times, and each time they want to pay before they leave, and they eventually got a bill months later, a total of over $1,000, which they happily paid, but they would have preferred to have paid it at the time. So in your reviewing of these procedures, can you give us the commitment that, but first question is, do you have a discharge procedure for the HSA now, which includes a paying of a settling of the account in one form or another?
Mr. Chairman, it depends on where the person is being discharged from, whether there will be ongoing charges still or not. There is a discharge policy in place where our patient financial services representatives do go to the patient and provide the information as far as the bill is concerned. And again, this is only in certain areas. There you can accept that there will be other needs perhaps that are ongoing where we can't say this is the final bill.
But the ongoing should be charges that are generated after the discharge fact. You should be able to say what the discharge amount is, because that is already incurred, and have that addressed in its totality.
For example, if from my understanding, if it is a patient that is in hospital and they are to be discharged because their care is now finished, they do get a final bill and a discharge bill that completes their encounter. However, as I said, there are many different areas that could be ongoing and perhaps develop and so forth. And sometimes doctors will not drop the charges until later in the evening and so forth, so they may not get the bill that particular day. This is why the board felt it necessary to bring in a firm to formalize the procedures that need to take place, so that at the end of an encounter, the patient has their final bill and can be discharged appropriately. I understand your thought process, and I didn't understand it at first either. And the medical specialist would be the better one to ask as far as what kind of examples, but there are...
My friend, the last person you want to get financial advice from is the doctor?
Not financial advice, sir. What I'm suggesting is the health advice, where they say that the person...
Yeah, but you understand the point I'm making is that anybody discharged will have a continuum of care, but the financial aspect of that continuum of care is to be incurred after the discharge. That should not affect your ability to have in place a proper discharge procedure that finalizes a bill and demands that it be settled in one form or another, even if it's a promissory note.
Yeah,
right?
There is a discharge procedure in place, and a bill would be given at discharge. If there are individual instances, then those should be taken up with the patient representative.
Mr. Chairman, through you, in terms of looking at the report now on page 17, paragraph 48, and in there the HSA, the executives and the professional staff is reported to have expressed concerns about the available level of staff support. The report talks about the doubling of the population, but the the size of the staff, the number of the staff in the public health programming had not changed. You also talked about the difficulties recruiting physicians because of the appropriate salary level or the offered salary level, especially with specialist physicians when you compare it to other jurisdictions or the private sector. I'm just trying to see what the board has done in this regard and to address, this particular concern. And a two-part to this question, and it goes back to something that the chairman raised about the capacity and the board certifications of doctors and the cost involved. Does the board ever get into an analysis of where the gaps are in terms of physicians, be it Caymanian or otherwise in Cayman, and then use that information to perhaps push or suggest a push to physicians going into those areas where we have the gaps in the country?
Through you, Mr. Chairman. Firstly, a cap had been placed on the HSA as far as the number of full-time employees could be, and that was at 840 employees, I do believe. We saw the need in the last year to hire additional, and we had to go to the ministry for approval on that, which they granted it in the particular cases because, as you stated, the population has increased, yet the number of employees hadn't increased proportionately. So we did, and we were able to get approval for the cap to be touched on, but it worked out that we didn't even need to due to attrition and some other employees moving along. So we do identify and recognize that there are needs as far as staffing are concerned. Financial constraints is one area. Again, this board has said this is what we need to move forward on. We need to be able to hire the doctors, hire the nurses, hire the specialists, whatever the position is, whether housekeeping, whatever we need, in order to deal with the needs of the country. Those, to me, as chairman, those needs can easily be met through collecting the bad debt. And that is why there's been a push to start as of April the 1st, as I stated, with a new vigor to get a clean opinion by December 2018. And in getting that clean opinion, the goal will also be to clean up the bad debt accounts. So we will be able to use money that the HSA makes in order to hire and provide appropriately. As far as the training for doctors, the clinical subcommittee of the HSA identifies areas where doctors are needed. If we can put in a Caymanian doctor, that is the ultimate goal and number one priority of that subcommittee. I co-chair that particular subcommittee at this time until the medical specialist, which we've invited, is able to join us. But I do know that that is a goal and priority for the clinical subcommittee. That subcommittee then reports back to the board with reference to whatever hires we can make as far as new Caymanian doctors are replacing doctors that are retiring or leaving for other reasons with Caymanian doctors. Additionally, Dr. Jefferson would be responsible for meeting with potential new doctors and saying and suggesting this is what we would need and this is how we could best fit you in the organization. And I know he has done that in several instances with young doctors, helping to guide them in an area of specialty so that they can fit in with the direction that the HSA is needed and intending and ongoing. You
say that you only saw this document a couple of days ago?
If this is the most recent one,
Yeah,
yes, sir.
the one that we're dealing with, ensuring quality health care and a healthy population.
I
The
think it
audit
was
report.
Monday evening. I got it. Yes, sir.
Well, your HSA is identified to provide the implementation or solving 3 of the 9 recommendations that the Auditor General recommended need to be addressed. Are you telling us that you were placed in that position in this response to the Auditor General without discussion as to whether you have the capacity to do so or whether you're willing to do so or
As far as the recommendations go,
yeah.
the board was not consulted on the recommendations prior to release.
I want to get back to this. What I'm a little concerned about the blurring of the lines of authority and responsibility and accountability between the minister, the ministry, and the board, because you keep referring to a good relationship with the counselor in the ministry. And the feeling I'm getting that a lot of this is happening kind of by the by and discussions in passing and meetings. But my concern is that there is adequate documentation which will allow for evaluation of what has been decided in terms of whether it achieved the outcome or the goal or not.
We have formal meetings with the counselor and chief officer every quarter. And when I say we, I refer to the deputy chair of the board, myself, the CEO, the chief officer, and the counselor. They are formal quarterly meetings. All minutes, of course, are sent through to the ministry. So they're not haphazard conversations. If there are, and I refer to the good communication with the counselor because the counselor is very quick to respond to any requests for information or direction when needed from the board. Not that they are haphazard conversations or behind the doors conversations. These are all formal requests from the board that the counselor or the chief officer, either one, both are excellent at responding to us for any information needed or direction needed.
And in that capacity, then either you, as chairman and the board, or the ministry, could look at those formal communications a year down the road and say, well, we communicated this directive to you, right? What has happened? This was our expectation of what would result from this directive. Is that kind of, because one of the things that the report strongly indicates is that that kind of matrix and evaluation process is very low, if it exists at all.
Right, as stated, our action item logs that we now keep on our minutes that are submitted would identify to the ministry where we're at with each of the directives and strategies. So they now have, like I said, as of September of 2016, they now have all the information as far as what the directives are being worked on and timelines and so forth, and persons responsible for these. So a year, 2 years, whenever down the road, they can look and say, okay, this was completed at such and such a date. This was the person or persons responsible for the completion of this and who signed off on it. So that is now part of the communication with the ministry on a monthly basis. The ministry, and again, it's FOIable. If anybody would like copies of that information, it's available. And it's something we put in place, like I said, within the last 6 months, because we felt as the auditor general would identify, that there was not a clear level of accountability when it came to the actions that needed to be taken. So the board has put into place where we now identify on a monthly basis where we're at, updates, if timelines need to be changed, and so forth. All of that is logged and attached to the minutes on a monthly basis.
One of the recommendations that the Auditor General made is item 3 on page 34. The government should strengthen its relationship with private sector care providers and two-way communication required for it to develop an effective healthcare system. The response from the ministry is, recommendation is noted. Responsibility is Ministry of Health, Department of Health Regulatory Services, and the Health Services Authority. What, if anything, has been done during your tenure to enhance the communication between the private sector and the HSA?
Mr. Chairman, the medical director, Dr. Jefferson, has had numerous formalized meetings with other private providers around the island, and those reports have come back to the board. So we have instructed the medical director to meet with other organizations and suppliers, perhaps, whatever we can use to be of benefit to the patient in order to better work with the other private institutions on the island. And in some cases, formal service level agreements have been signed.
Sorry, Chairman, mine was going back to the last item we were talking about. So a comment and a question, if I may. Firstly, the comment was this report came out quickly. It was made public on Friday, and therefore, you know, I appreciate that for the Chief Officer, the communication would have been through the Chief Executive Officer of the HSA, just in accordance with trying to keep it tight before it goes public prior to publication. So just to put that bit of context around it. And then the second, which was relating back to the ministerial directives and monitoring performance against them and how you as a board do that and report back to the ministry. That's all good and fine because it sounds very much like it's progress against actions. So a task list of things to do. I suppose the thing that conversation and earlier conversations begs for me is how, as the board chairman of the HSA, do you assure yourself that the performance of the HSA is contributing to improving the health and well-being of the population? So how's that connected then to health outcomes and the stated aims of this policy and strategic plan?
First of all, through you, Mr. Chairman, it's not certainly not an easy task to say immediately that all directives would directly relate to or affect the health of a particular patient. It may be related to the experience they have in receiving health care. So those are some of the things that we look at, go through the directives. We're able to identify that as these directives are and action items have been completed, we're able to monitor and get updates on them to know that they have not just been put in place and once used, but monitored on a regular basis through the responsible persons. Again, I had stated every action item has a person or persons responsible for completing or in implementing the action. So it's not a matter of just putting these items out there and no one's responsible for it. There's also a report back time as to when the people that are responsible for it would report back to the board or their supervisor for these items to be either adjusted if need be, because as we're aware, we met this in the past with the pharmacy software issue. When that was installed, it was quickly understood that this was not working, and so we did have to make a quick reevaluation of it. So we put into place timelines, persons responsible, reporting timelines, and so forth to be able to identify whether they're being met. To finish off the question, you asked in regards to the health of the country. Some of those things will take time to be able to measure. So I can't say that there is a specific rubric that we were able to use to measure to say this directive has helped in this way. But each of the action items are tied to the directives so that we can identify that we are meeting as a board the directives from the ministry.
Chair, if through you I may follow up on that, because I was hearing that the directives were things to do, and do those things produce better outcomes was one part of the question, but the other part of the question was, forgetting the ministerial directives and the monitoring of those, what management information, what do you as board chairman have that helps assure you that the health and well-being of the population is improving? So just trying to get at the management information that the board get.
The reports from the medical director as far as patients and needs of patients coming to the board would be the closest that the board itself gets. In order to assist if there is an identified need from the medical specialist that, for example, there's an increase in hypertensive needs and so forth. That would be brought to the board's attention, and in conjunction with the medical director, we would identify the quickest and best way to move forward with addressing those needs. So medical needs would come from the medical director or the clinical subcommittee.
You got to follow up. Can you tell me? Can you give me how your board is made up now? Who the members are?
Yes, sir. You like a list of each of them?
Yeah.
Myself as the chairman, Kerry Bergstrom, deputy chair. We have Gordon Madison as finance director. We have Arthur McTaggart as the IT director. Christina Kirkcaldy as HR and clinical, HR, and clinical member. We have Ms. Jenny Manderson, HR again, and we have Mr. John Magoo as far as legal representative.
That's a curious makeup, given that one of the things that are clearly identified in here is the lack of communication between the private sector healthcare and the public healthcare. And I'm constrained to ask you how you could justify recommending the ministry have the chief officer sitting on the board and the Minister of Finance have somebody sitting on the board, but we don't have any representation from CIMDS or private sector physicians.
Mr. Chairman, I stated earlier that that we are in the process of getting a doctor to sit on the board as a consultant, and that's something that they would be able to assist us with chairing. And it's minuted in our meetings as well, that they would be assisting with chairing the clinical subcommittee as well, so that there would be an aspect of private sector inclusion.
So that specialist is coming from the private sector?
That's correct.
But that specialist is going to be handpicked by whom?
The HR director has been in communication with several, and Ms. Kerry Bergstrom has been in communication with several doctors that are willing to serve on the board.
But
go ahead.
Do you see any risks or conflicts in that kind of a process, as opposed to having a person who represents the private physician or the medical fraternity as a whole being recommended by the Cayman Islands Medical and Dental Society?
I understand what your point is, Mr. Chairman. However, there has to be the issue addressed of how or why would that person in particular sit on the board that could determine many things as far as the health and the particular organization, when you have someone that is working at a private institution and they sit on the board, there could be a lot of information that is divulged that may be proprietary. So we have to look at both sides of it. Whereas if we have an invited guest to say, can you come and attend these meetings? We need some consultation. What is the private sector feeling and so forth? It allows us to have a little bit more control over what information is given out per se.
Mr. Chairman, just through you and I guess following up on the Auditor General's intervention about the management information that you guys are having, or that the board is receiving and then making decisions on page 29 on paragraph 99. It said that the HSA tracks the number of patient complaints, and that, given benchmarks from with the Miami area, etc., scores of about 75 out of a total of 100, meaning 100 is high satisfaction. For the period of January to July 2016, the trends at HSA services was the score was below 50%. What is the board doing with that information and addressing those types of data that it receives?
Through you, Mr. Chairman, our patient representative is receiving additional help from another management member in working with our patients who are not satisfied. The CEO herself has been involved with several of these cases as instructed by the board for her to get involved to make sure that the patient leaves in a satisfactory manner. So that has been identified. If I'm not mistaken, Mr. Chairman, has been in June of 2016 when that particular issue was looked at from the board perspective, and it noted that there was a concern that patients were not satisfied when there was a complaint, and the CEO had been instructed at that time to become involved in those matters if the need arose. So in other words, she was to make herself available to patients who had complaints that were not being satisfied by our patient representative.
In terms of total health expenditure, and we heard yesterday from Cynical, basically, government assumes responsibility for the unhealthiest sector of the population, and private sector basically then takes the healthy cohort. Have you ever, as a board, come back to the government with suggestions in terms of, why are we being kind of charged with taking on the worst case scenarios, and presumably that would lead to, I'm trying to couch this in the best possible way, some of the issues that you're facing, meaning, if people are very unhealthy, they're coming in, your results then are going to be lower in terms of overall turnaround and effectiveness. Does the board ever look at that cohort and go back to government and say, well, here are some note items that we need in any kind of evaluation of our performance services, et cetera. We need to put an asterisk on the type of patients that we're getting in general, or does that never come into play?
Through you, Mr. Chairman, we don't turn away patients regardless of their health condition, as I'm sure you're aware, and we can't say no to people regardless of their health. One of the things the board has recognized is that there is a larger audience out there, and through the addition of communication managers too recently, we are in the process of revamping our public relations and attempting to get business from the private sector as well, as you've stated, realizing that that we can provide for them perhaps better than their current provider. So the board has recognized that, and we are on a campaign to work towards that.
Yeah, because that was my point as well, in that we heard from the chief medical officer this morning that, there's so many services and enhancements and other things at the HSA. And, while it's good, that we have a place where, our sickest or unhealthiest or that side of the population can go to, it, in terms of revenue and the financial side of things, part and parcel of trying to balance that out is to inform the public of all the services, market the services. I mean, we attend all these health conferences that come in, and we see the Florida hospitals advertising all their services, but you don't necessarily see the same HSA advertising and things like that. So a counterbalance would be to go after some of that, the healthier ones that are coming in for maybe sometimes elective or other services to support that mix.
Mr. Chairman, through you, one of the areas, as I said, identified is the fact that we don't tell our own story very good, and the hiring of 2 communication managers, one internal, one external, to allow us to tell our stories better and more frequently is something that the board had identified and is now in place. So you will see going forward a lot more positive results as far as the stories being told coming out of the HSA. You will also be made aware of the services provided, because as the member has definitely and correctly stated, a lot of people are not aware of all the services we provide at HSA and to what extent. Many of the things being touted by other institutions on the island have been done at HSA for many, many years. And so the goal for the communication and public relations aspect and public awareness aspect is to let the general community know what's available, how easily it is to access it, the fact that we're central. You don't have to travel far away to deal with it, and you can recuperate right in your own home. So those are some of the things that the board has identified and is looking forward to being able to produce or continue to produce, as has already started in the last few months.
Mr. Chair, my last question for the morning is, given the comprehensiveness of this report, and I would recommend, I guess, to the board really delving down into the findings, the recommendations, and perhaps using this in terms of that governance and strategic, side of what the board should be doing. Because I think that if some of these things are taken on place, A, the analysis, B, the reporting, C, the outcomes will be better kind of identified, tracked, and tweaked from time to time. Because having read it as a layman and not being on any kind of health related boards, I think it was a great kind of a starting point, a baseline to at least have the parameters outlined where you could use it as a template going forward to build on. But that would be my recommendation from viewing it.
Through you, Mr. Chairman, thank you, member, for that recommendation, and certainly we will continue to look at how best the HSA can implement the recommendations. We've had 2 strategic retreats in the last 2 months, identifying on the best way forward to improve the services, to provide the outcomes, and to be able to track changes and make the organization one that is to be envied as such by other institutions. So I certainly appreciate and take into account your recommendation.
On page 29 in the report we're dealing with, the Auditor General compared the number of physicians and other support.
Yes, sir.
Does the board feel any need to influence government policy? Or does the board have any concern that we may be approaching the point of oversubscription and provision of some of these areas, which is going to lead to escalation in costs? For instance, we have in Cayman almost double the number of physicians per 10,000 that Canada and United States has. We're down a little bit on nurses. We're higher in dentists. Yet at the HSA, the dental appointment schedule is running, what, 3, 4, 5 months? You can't get an appointment to see a dentist. Do you feel any urge or responsibility in trying to influence the policy of the ministry in terms of limiting these providing any limits to this through the MDC and other places?
Mr. Chairman, I do recall reviewing the particular chart. There are, of course, some basic needs with the economies of scale, as you're well aware. If you even look at Faith Hospital in the BRAC, I don't think there's anywhere in the world that has the doctors per population as good as that. Perhaps Little Cayman may be better, but as you can appreciate, 4 full-time doctors for 2,000 people certainly is a very good ratio. But there are certain basic needs that you have with a community this size, and then again with being able to grow the organization to handle the ever increasing needs of the population, to improve quality of life and so forth. As far as limits go, I think the organization itself has identified and recognized that there are perhaps areas that we need to look at more so than others. As you stated, dentistry is one area we need to address, and I know personally that the board has taken that into consideration and is working on several areas to improve appointment times and so forth, as well as women's health. So we do know that there are particular areas. Having a high number of doctors per 1,000 people is only as good as having the right type of number of doctors per 1,000 people. So that's one area we are working on, realizing that if we have plenty of doctors but in the wrong area, it's of no use to the community. So I don't know that we would make a recommendation to the government, but rather internally reorganize to be able to meet the needs of the community.
Do you have any questions, Joey? Okay. Sorry.
Thank you, Mr. Chair. Just as a matter of clarification and with regard to the audit process that you were discussing with Mr. Tibbetts, when we do clear our reports, when we're conducting our audits and clearing our reports, we respect the accountability framework in place. And that's very important to us. So, for example, when we're auditing core government, we are discussing our audit findings and our concerns from the evidence that we collect with the chief officer or Mr. Manderson, depending on the situation. At the SAGC level, we're dealing with the CEO. However, in both cases, we expect, obviously, when we're raising the matters and there's concerns that they, in responding, would be, there might be issues with providing a response to the Auditor General in terms of the recommendations. We fully expect the CEO or the chief officer to discuss that with the minister, just to make sure that that's just common sense. But from our perspective, our role would be to ensure that the report is cleared, all clearance takes place with the senior administrative official.
And it is also fair to say that while the public unveiling of it was short space of time, giving like the development of the report and the opportunity to respond, there were no short periods of time. Nobody was restricted, and it took the normal course. In fact, I think this one took a couple of months longer than it would normally, because you were waiting on that expectation to take place. So there's some disappointment that they hadn't heard about it from the committee point of view.
But again, to be fair, Chairman, the recommendations don't come until a late stage in the report, because inevitably we need to do the field work first. So this has been quite a truncated process, to be fair.
The point I want to make is that you didn't give them the recommendations and wanted there was not a shortened window to respond to the recommendations. There was the normal time frame was given. Well, Mr. Tibbetts, thank you very much for coming, and we appreciate you taking the time. Thank you very much.
Thank you, Mr. Chairman.
We'll reconvene at 1 o'clock.